Hello and welcome to Oral Pathology. My name is Miss Griffith, and today we will be talking about oral pathology, which is one of the most significant subjects in the dental hygiene curriculum. One person dies every 4 hours every day from oral cancer. This statistic has not changed in over 40 years. This is why it is so important for each and every one of us, to understand oral pathology and to provide thorough extra and intraoral examinations that will ensure identification of abnormal conditions as early as possible. Okay, let's get started. First chapter, Introduction to Preliminary Diagnosis of Oral Lesions. This is one in which you should be familiar with, and we're going to be sailing through this. You're off and running. You're doing a lot of this in clinic right now, and a lot of this is review, but it's also very basic in which you need to get a good foundation. The outline is very complete and comprehensive in each chapter. Need you to really concentrate on the vocabulary. This will help you with the diagnostic process, in which you will be using multiple different types of diagnosis in illuminating what is normal and variants of normal, and what are benign conditions, also known as idiopathic. Vocabulary. We'll be looking at the clinical appearance of soft tissue. Is it a nodule, or do we just feel it by palpation? What is the consistency of the tissue? Is it firm, or is it squishy, or does it move? The color of the lesion. Is it dark brown? Is it red? The size of the lesion. Is it just well circumcised and 1 centimeter or less? Or is it larger than 5 centimeters? Or does it take up the whole side of the face? And what is the surface texture like? Is that going to be smooth and bulbous? Or is it going to be like an ulcer? We'll be also looking at the radiographic terms used to describe the lesions in the bone. Slide 4 shows the clinical appearance of soft tissue lesions and how they may vary. This is showing a bulla. A bulla is a circumscribed elevated lesion that is more than 5 millimeters in diameter. It usually contains a serous fluid and looks like a blister. When they're grouped together, it's called a bullae, and this is seen in erythema multiforme, which occurs when the skin's immune reaction to an infection or medication can trigger it, combining the Latin word erythema, redness, and multi, many, and form, shaped, as described with the rash on the body where each mark resembles a bullseye. In this slide, we are looking at a lobulated torus palatinus. Lobulated meaning that it is a segment or a lobe that is part of a whole. These lobes sometimes appear fused together. To me, it kind of resembles bubbles. If you blow bubbles, it's not always just singular like a bulla. It can be multiple ones at once, kind of layering on top of each other, and you can kind of visualize that as lobulated. A macule is an area that is usually distinguished by a color different from that of the surrounding tissue. And here you can see the darkening, which is kind of looking dark brown on the lip, which is a light pink, and it's not raised, it's flat, and it does not protrude over the surface of the normal tissue. A freckle is an example of a macule. We do not describe this as abnormal. In contrast to the macule is a papule. You can have lots of fun with this. One is an M, one is a P. The papule, think of it like a pimple. It's going to extend above the epithelium layer of the skin, unlike the macule, and It is small, circumcised, less than usually 1 centimeter in diameter. An example of this is lichen planus. In slide 8, you can see a pustule on the left-hand side. It is a large, bulging patch of skin that is full of a yellowish fluid called pus. It contains dead blood cells, leukocytes, which leuko meaning white, but now it's not white, with dead neutrophils in it and debris, and serous fluids, in which, remember, serous fluid is separation when blood coagulates, and it's the watery plasma. A good example of a pustule is seen in acne. Now, not all acne will have pus in it. However, that would be nothing that we would really document on the medical history if it's just regular acne. However, when it goes to the next stage of becoming a pustule, that's when we would document on our medical history where it is and how large it is. So we're looking here that it is on the upper lip, on the vermilion border towards the midline. And it looks probably like it's about maybe 4 centimeters from here at a distance. It is different than a vesicle. And the vesicle is a small elevated lesion, less than 1 centimeter in diameter, and it just contains serous fluid. Again, the serous fluid is the watery fluid. It does not contain pus in it. This is a picture of a pedunculated base with a fibroma on top. It looks like a mushroom. The fibroma is a fibrous hyperplasia, and it's most common tumor of the mouth. It is from an irritation, and it is also something that is asymptomatic. It usually occurs within 1 to 2% of the general population. It looks like similar coloration of the rest of the mucosa surrounding it. Let's look at this fibroma that has a broad base, and we call that broad base with the fibroma a sessile. It's describing the base of the lesion that is flat or broad instead of stem-like, which was the previous pedunculated fibroma that looked like a mushroom. Let's go on to soft tissue consistency. Okay, we're going to talk about not only just seeing, this is when you're going to be feeling. So we're going to use another sense. We're going to feel a nodule. A nodule is a palatable solid lesion up to 1 centimeter in diameter. It is found in the soft tissue, and it can occur above or below the skin surface. We feel this with our fingers and with our hands, so we can support, because a lot of times when you're on the floor of the mouth, you need something to oppose it, so that's why you'll rest your other hand underneath the chin for support. So you'll palpate around. So you're looking for any type of feeling with your fingers to determine the texture of that area. You're going to use descriptive terms if it's soft, if it's firm, if it's semi-firm, or if it's fluid, and you can move it around. Another important way to describe a lesion is with color. And this is something that you must incorporate into your general descriptions. Most colors frequently describing the oral cavity would be red, pink, salmon, white, blue-black, gray, brown, and black. It's used to identify specific lesions. The lack of detailed descriptions of the oral lesions can lead to difficulties in prioritizing appointments needed for treatment and also the differentiation of the lesion. Here we have a picture on the upper left-hand side of erythema. This is an abnormal redness of the mucosa of the gingiva. You can see the bright redness This appears that the patient had a denture in there, might have been allergic to it, causing inflammation. Possibly he might have left it in a while and there might have been some debris underneath the denture in which there was constant rubbing causing inflammation. But we know that if it was continued on and left there, that it would probably lead to ulceration, which would take a lot longer to heal. So it's very important to see, what stage the patient is in with the color. Also, pallor identifies a paleness of the skin or mucosal tissue. The tongue is showing kind of a palish color pink, okay, but then there's other colorations in it. To me, it looks like a geographic tongue, and or a patient having melanin diffused into their tissue, which the melanin is a darker pigmentation. In slide 13, we are looking at the color of a lesion being red or erythemic. This lesion is called erythroplakia. It is a clinical term used to describe an oral lesion that appears as a smooth red patch or granular red and velvety patch. 90% of erythroplakias demonstrate epithelial dysplasia, dysplasia meaning an abnormality of development of cells. However, that does not always mean cancer. However, this picture does show it is squamous cell carcinoma. Another term is leukoplakia. Leuko meaning white. In the next slide, we'll go over leukoplakia. In this slide, we are looking at leukoplakia. Leuko meaning white from the Greek language, and it means it cannot be scraped off. It usually doesn't cause permanent damage to the tissue. However, leukoplakia increases your risk of oral cancer. That is why it is advised that people that are chewing tobacco and they have dysplasia or a change on the tissue should be advised to change the location. Something that is consistent over a long period of time often leads to cancer. This leukoplakia is usually associated with heavy smoking, use of chewing tobacco or snuff, chewing also betel nuts. And that is something that is grown in the tropics of Asia. Another way to describe a lesion would be utilizing our periodontal probe to show the size of the lesion. With the periodontal probe, it would be measuring in millimeters, 1/1000th of a meter. We could do it horizontally and also vertically. Also, you can do the depth of it. This is also good in showing the classification of the occlusion and how much overbite we have utilizing the periodontal probe. Another way is using a centimeter, which is 1/100th of a meter, equivalent to a little less than 1/2 inch. In slide 16, we are utilizing the centimeter ruler on the upper left. On the upper right, we are using our periodontal probe, which I love to use, and it is measuring the size and circumference of the fibroma with a sessile base. In the lower right X-ray, the periodontal probe is seen, showing the base of the periodontal defect. In the lower left-hand side of the X-ray, we can see a gutta percha point, and there are different ways to describe the surface texture. One way is being wrinkled or corrugated, as seen on the upper left picture. You can see there's many grooves and crinkling and wrinkling of the tissue. On the upper right, we see a tongue that has very deep, prominent grooves. This is called a fissured tongue. On the lower left, we're looking at a picture, kind of looks like baby Bigfoot, but actually it's a papillary. It has small nipple-shaped projections or elevations found in clusters. And this is often seen with HPV viruses, and there are many different types of HPV viruses, up to 130 different types. And a lot of them can be malignant, pre-malignant, or not malignant at all, benign. Another way of describing the lower right is saying smooth, which is opposite of rough or folded. Jumping on to the radiographic terms used to describe lesions in bone, we can see a radiograph showing ameloblastoma, and it has multiple radiolucencies that have all joined together or coalesced to form one whole. So that's what we're looking at, coalescence of multiple ocular radiolucencies to form a whole. Another radiographic term is diffuse. This describes a lesion with borders that are not well defined, making it impossible to detect the exact perimeters of the lesion. This can make the treatment more difficult and, depending on the biopsy results, more radical. Radical meaning that it is not just confined to maybe like 1 inch. It could proliferate, expand out to be 2 inches or more, or including the whole arch. Another radiographic term to describe a lesion is multiocular. This is describing a lesion that extends beyond the confines of one distinct area. It has many lobes or parts that are somewhat fused together. The multiocular radiolucency is sometimes described as resembling soap bubbles. An example of this is odontogenic keratocyst. Another radiographic term which you're familiar with from radiology is radiolucent. This is when the structures are less dense and it permits the X-ray beam to pass through it easier. Here, as the arrow points to it, is the structure of the pulp. Also, you can see cavities that show up more distinct in radiolucency. Radiopaque is another description of showing an area on the X-ray that is white or lighter in shade. This is opposite of radiolucency, and with radiopaqueness we can tell restorations. We can also see the bone height, and this is because the X-ray beam and light is not able to go through this material because it is more dense. You may also use the same terms, radiolucent and radiopaque, in describing an X-ray. This is the mixture of light and dark areas within a lesion. This can also denote the different stage of lesion development. Oftentimes when a patient is having sensitivity, we might take an X-ray and note that there might be a little bit of radiolucency around one tooth. The following week, we can take another X-ray and we can see a distinct circumscribed area showing a abscess. Root reabsorption, you can have either internal or external. This is an X-ray that is showing The apex of the tooth appearing shortened and blunted and irregularly shaped. It occurs as a response to stimuli which can include a cyst, a tumor, or trauma. Oftentimes, if a patient, you see this sometimes in adults that are having braces and have it done too rapidly, that you have from external force of the orthodontics, you have shortening of the roots. This is not good because, again, if the patient, after having this type of treatment and blunting of the roots, if they do have periodontal disease, they have a less likelihood of retaining the tooth because there's not as much tooth in the bone for structure. External root resorption arises from tissue outside the tooth, such as the periodontal ligament. You can see the radiolucency, and you can see the cementum and the depletion of it in this x-ray where the arrow points to. Opposite of external root resorption is internal root resorption. This is triggered by pulpal tissue reaction from within the tooth. Internal, within. The pulpal area can be seen as a diffuse, spread out radiolucency beyond the confines of the normal pulp area. In slide 27, we are seeing scalloping around the root with a radiolucency. The radiolucent lesion that appears to extend up the periodontal ligament and between the roots. In this x-ray, we were looking at a unilocular, having one compartment, uni as one, that is well defined or outlined as in a simple radicular cyst. This is important possibly with more diagnosis. It could mean that the patient might need a root canal. This x-ray is showing a lesion with borders that are specifically defined in which one can clearly see the exact margins and extent. We call this well circumscribed, which is the opposite of diffuse. Switching gears now, we're going to go into the diagnostic process. This is going to utilize what we had just previously gone over, the different types of description about what we are seeing, both inside the mouth and using radiographs and palpation, and sometimes you could use your sense of smell. So that is part of the clinical diagnosis. Also, we can see radiographs. They're very beneficial in helping us see what we can't visually see looking in the mouth. Another way is historical diagnosis, getting to know the patient, their family, and possibly genetics, such as diabetes. Also, laboratory diagnosis, going into microscopic diagnosis by taking a brush or excising in a surgical diagnosis, and also using therapeutic diagnosis, different types of medications, and also using a conglomeration of many types of diagnostic processes called the differential diagnosis. Let's begin with clinical diagnosis. How does the lesion present itself to you? The color, the shape, the location, and the history of the lesion. Again, how does it look to you? And this is how we're going to document it. This is a picture of Fordyce granules. They are papules and are seen on the soft tissue in variations in the oral cavity. They are atopic, sebaceous glands characterized by yellowish-white papular lesions scattered throughout, usually on the buccal mucosa and the vermilion border of the lip. Torus palatinus is normal. It's harmless. It's a painless bony growth located on the roof of the mouth. This can be a singular, or it can be a conglomeration as seen in this picture and lobulated. It does present a problem if you're having a prosthesis up there. Mandibular torides also occur. Usually they're unilateral, and they can be on the inside of the mandibular arch or on the exostosis, which is the outside of the arch. On the left-hand side, we can see a picture of melanin pigmentation. A lot of times this is genetic, but also there's also other factors such as tobacco smoking, called smoker's melanosis. On the right-hand side, we see a picture of the retrocuspid papilla. This is seen on the lingual aspects of the cuspids on younger children, and usually it diminishes over the years when they become about 20. Again, it's very important to describe what we see clinically. That's what we see is our clinical diagnosis. We can see a fissured tongue is normal, but it shows that it has very deep grooves. And also look on the borders of the dorsum of the tongue, the top of the tongue, and we can describe that. So it's scalloped around the borders of the tongue and also has deep grooves or fissures on the dorsum of the tongue. On the middle picture, we're looking at a geographic tongue, but it's showing a rhomboid glossitis. The rhomboid presents itself because it is lacking the filiform papilla. This often presents high sensitivity for the patient. We like to suggest for them not to eat, let's say, acidic foods. And oftentimes the rhomboid glossitis comes about through, it's more intensified if the patient is under a lot of stress. And that goes along with the geographic tongue. Why do we call it geographic tongue? Because it's constantly moving like geography. And so that's where one time you might describe, I see this large, loss of papilla on the dorsum, the right dorsum of the tongue. The next time they come in, it could be on the left side of the tongue, on the dorsum. It's geographic or moving. Slide 36 is showing clinical diagnosis of a white and black hairy tongue, which are normal. And we'll go into more discussion on that in a few minutes. And also, we can see the circumvallate papilla. Now, the reason with this one is it's very large. It's not abnormal, but we might want to also jot that down on the description of what we see. Moving forward, we're going to use the clinical diagnosis, what we see, and also the historical information, what has happened in the past to the patient. Where the arrow points, we see a bluish-blackish discoloration. Now, when we further ask the patient, what did you ever have a filling on this tooth or a previous tooth? We find out from the patient's history that they had a root canal on a deciduous tooth, because on this permanent tooth, the central, there is no amalgam, so there would be no amalgam particles that go into the tissue that would cause the discoloration. So history is very important. In this picture, we're looking at the presence of a fistula that's warranting a radiographic image. You can see above the lateral a bright red nodule. The radiograph will show information about the apex of the root and if there is a lesion around it. Again, this is a review of the radiographs. We see many things. On the right-hand side, The arrows are pointing towards calculus. This shows that there's multiple sites, mainly and proximally. The patient probably doesn't floss at all, and we have lessening of the bone. So you see a lot of radiopaqueness in here, along with the fillings. On the lower left-hand side, we see external resorption. Again, that's external on the outside of the root. On the upper left, we're looking at a periapical pathosis. There's some kind of inflammation going on where the arrow is pointing, and it's on the external, on the outside. In this slide, the circles are supposed to be around the caries. However, I think they're just off a little bit. The caries present itself as radiolucent, where radiopaque, more light or white, shows definition of a filling, or a root canal post, or a root canal. Okay, this is showing pathology, something that we would not detect looking in the mouth, but we would use the x-rays to help diagnose what is going on inside the person's bone. The example on the left-hand side is a compound odontoma, which is also known as an odotomy. It's a benign tumor linked to tooth development. On the lower right-hand side, we see complex because there's multiple ontomas in it. So it's a complex one, meaning several. These x-rays are extremely important when a person is going to have orthodontics. Supernumerary teeth, extra teeth coming in, impacted teeth, how they're sideways and they're pushing against another tooth. A lot of times we'll see this on third molars. And also, it helps in the treatment of which teeth the dentist will be extracting or keeping. Slide 43 shows calcified pulp in the mandibular first molar, along with partial calcification in the bicuspid. This would be important for an endodontist because when they go in there to use their files, they're not going to go down there as well as they would if there was just a plain canal. Okay, when we look at this x-ray first, we're going to see, look at the bone level. You're obviously going to need to hold on to these teeth while you're curetting around them or scaling. But the neat thing, if you look closer at the apex of the tooth, you can see nutrient canals. That's how the nourishment goes into the tooth. So even though there might not be a lot of bone around these teeth, they still are vital. Here we see radiographs that are normal. They're anatomic landmarks such as the permanent teeth and the deciduous teeth as seen on the x-ray on the left-hand side. Patients love to see that. Also, we're looking at on the right-hand side an unusual finding, and possibly that could be just maybe if someone put a stone on their tooth for decoration. Okay, here we're looking at some unusual findings on the x-rays. On the upper left, we're looking at some amalgam fragments, which would give us an amalgam tattoo. On the right-hand side, we're looking at an overextended filling. It's an overhang, and a lot of times when we see this, we're going to drag the floss on it, it shreds it, and you can see how it interferes with the growth of the bone and it'll present just like calculus, inflammation and bleeding. So a lot of times with these, the dentist is going to want to redo it. Another unusual finding is on the lower right hand side where the arrow is pointing. This looks like it could have been from eyeglass frames or sunglasses. On the left hand side, you can see that there's partial metal in there, and that could have been from a instrument. Yuck! So you have to be very careful again with sharpening your instruments. Over sharpening instruments can make them very fragile and easily be fracturing in the patient's mouth. Okay, these are a continuation of unusual findings in the mouth. On the upper left, we're looking at a little hook, and that tends to be, from our clinical diagnosis, a nose piercing, and that's how it shows up on the x-ray. On the upper right, we see an impacted tooth because we can tell that it has an occlusal amalgam in it. On the lower left, this is very, very unfamiliar or not something that you often see because it's a retained metal such as a shotgun pellet or a sharp nail. Now when you take an x-ray, a PA of this or a bite wing, and you see this, which is on the lower right of the x-ray, it's round, and you're thinking, what's this radiopaqueness? I know they're not going to put a big filling down there. And so you ask a little bit more, getting the history of what's going on, and the patient tells you, I was shot one time, and this is, some of the metal left in there, possibly. Then you ask the dentist, and he'll say, why don't you go ahead and take a Panorex? So on the lower right, you're seeing where the arrow points to, that is the piece of metal or the shotgun pellet that was seen on the lower left. Okay, let's delve into historical diagnosis. This is where we want to start using our process of elimination or being inquisitive. Let's look at the personal history. Okay, let's look at the family history. Is there a family history of possibly their enamel in which they're all pitted? Do they have, a lot of, that could be genetics. If it's personal, do they drink lots of sodas? And they would have a lot of erosion and abrasion. Also, we look at the past and the present medical and dental histories. Did they have high fevers in which it disturbed the formation of the tooth enamel, or the history of drug ingestion? Is there a discoloration of the enamel from possibly utilization of the drug tetracycline, in which they would have tetracycline teeth, or the grayish appearance? Also with this, that would also factor into bleaching, because patients with tetracycline stain do not present with a great satisfaction of whitening because of this. Also, we look at the history presenting of disease or lesion. And this could be in factors of medications that they're taking for their high blood pressure and channel blockers. Looking at the historical diagnosis, the family history is very important. One disorder of the tooth development is called ameliogenesis. This is where there's unusually small, discolored, pitted, or grooved teeth that are prone to rapid wear and breakage. It also occurs in other parts of the body, and this is genetic, and so it goes back to the family history. Another genetic disorder, going back to the family history, is dentogenesis imperfecta. And this is where you're having the lack of dentin To get more of a more complete historical diagnosis, we want to use medical past and dental status from the patient. An example of this are the ulcerations in the back of the throat on the upper left picture. You see the ulcerations, and from looking at the medical history, you notice that the patient has a problem with ulcerative colitis or acid reflux, which promotes the lesions in the back of the throat, such as this, or decalcification of the teeth. An example on the right side, upper right, by looking at this, clinically looking in, you might think, this patient really has bad hygiene. Look at all this inflammation, the glossiness, the bulbous of the tissue. However, if you look at the medical history, you might note also that the patient is taking a Dilantin for epilepsy or other medications such as in this picture, channel blockers, calcium channel blockers used for high blood pressure medication. In the lower left, we see a allergic reaction on the patient. So you might want to find out, hey, what caused this, or how did you get this? And it could be possibly that they're allergic to latex. So you definitely want to have your nitrile gloves on. Looking down at the lower right hand two slides, okay, these are both where the patient had tissue adhered onto their alveolar mucosa, okay, in periodontal treatment. One, the left side is on a white patient and the healing is going well. However, on the lower right hand side, same type of treatment, but this is on a darker patient of color, and you can see the blackness. At first, that's very alarming and everything, but looking into it more, you can see that, a lot of times trauma will cause black disfiguration or coloration in the tissue of dark colored patients. Let's go into laboratory diagnosis. This includes blood chemistries, urinalysis, and cultures. Looking at this x-ray on the left-hand side, we see an appearance of cotton wool. This is where we have diffuse radiopacecies, giving it a cotton wool effect in the bone. All right, now further, after seeing this, we might want to do a blood analysis in which it shows elevated serum alkaline phosphatase levels, and this would lend itself more to being the Paget's disease. So the microscopic diagnosis often is the main component of the definitive diagnosis. The trick here is getting adequate tissue sample that is necessary either in a brush technique or a surgical technique, so it can be identified properly under the microscope. A brush test can be used to obtain information from the oral mucosal epithelium for a microscopic diagnosis. A circular brush, which is usually stiff, is used to obtain cells from the full thickness of the epithelium. The results of this test may help determine whether a scalpel biopsy is needed to establish a definitive diagnosis. A microscopic diagnosis is used for a white lesion which cannot be diagnosed on the basis of clinical appearance alone. Utilizing the microscopic appearance, it can vary from a thickening of epithelium to epithelial dysplasia, which can be pre-malignant. A surgical diagnosis may be needed for such as a traumatic bone cyst. Now, you remember that we talked about a traumatic bone cyst may appear as a radiolucency that scallops around the roots and also interproximally. When the lesion is opened surgically, there's an empty void in it. Now, a traumatic bone cyst is not dangerous. However, if it is painful to the patient, the dentist probably would want to surgically look in to see if it is something that might be more traumatic. Slide 56 shows another case in which diagnosis using the surgical means is helpful in diagnosing the lingual mandibular bone cavity, static bone cyst, or Staphon bone cyst. When it is surgically examined, it appears to be a well-circumscribed radiolucent area revealing salivary gland tissue entrapped during the development. And of course, by taking the surgical procedure, the tissue is then given to the lab to do a microscopic examination to further diagnose. A therapeutic diagnosis is used to recognize a nutritional deficiency as seen in this picture for angular cheilitis. This may be associated to vitamin B12 deficiency or lack of vitamins. Most commonly, it also is a fungal condition and responds well to a topical application of nystatin. This is a picture of the infection which is caused by an abnormal overgrowth of bacteria that normally exists harmlessly in the mouth. Poor oral hygiene is usually contributing to this development of ANUG, acute necrotizing ulcerative gingivitis. Also, emotional stress, poor diet, and lack of sleep contributes to it. It begins abruptly and very painful and bleeding excessively. Sometimes there's a very foul-smelling odor, and it's very distinct. Patients feel that there's wedges between their teeth, and there's a lot of pain, and they might have a taste of a metallic taste. It also responds well, the therapeutic, to hydrogen peroxide, since the bacteria is anaerobic and does not. Okay, let's go into the differential diagnosis. This is the point in which the diagnostic process, when the practitioner decides which test or procedure or procedures are required to rule out the conditions originally suspected and to establish the definitive or final diagnosis. Hygienists, I consider you as the frontline workers. It's very important for you to be observant, to listen, to look, to feel any type of collection of data using the medical and dental health histories, history of a lesion, clinical description and evaluation, biopsy reports, microscopy reports should be collected from the patient and also their chart. We see the patient much more than any other person in the office, including the dentist. We are with them from 45 to 60 minutes or longer for each procedure, either it be biannually or every 3 or 4 months. We can look and see, hear what the patient's saying, and be observant enough to ask questions when needed. Okay, let's go into variants of normal. Variants meaning that some, but not all, people have these conditions, but they are normal. An example of this is Fordyce granules, the torus palatinus, mandibular tori, melanin pigmentation, retrocuspid papilla, lingual varicosities, linear alba, and leukodema. Slide 62 shows pictures of Fordyce granules. Now, these are clusters of ectopic, meaning they don't usually occur in the mouth, sebaceous glands. They appear as yellow lobules in clusters and commonly observed on the vermilion border of lips and buccal mucosa. There's no treatment necessary for these. Torus palatinus is often seen in women, occurring on the midline of the hard palate. It is an extra growth of normal compact bone called extraphytic growth because it's outside and we can see it, and it is usually inherited. It occurs gradually, and then over the years it can grow larger and larger. It can be seen as one lobe, or it can be lobulated, as we had discussed earlier. It may take on various shapes, and it's normally covered with soft tissue. There's no treatment that is necessary unless there is interference with speech, swallowing, or a prosthetic appliance. Looking at this x-ray, where the arrows are pointing, we think, what is this radiopaqueness? But looking clinically in the mouth, we can see that is from the palatine torus. So that's another way in which we can do our diagnosis with radiographs and clinically looking in. This is a picture of mandibular tori. It can occur in both sexes, male or female. It can appear fused together. It can be bilateral and lobulated or nodular. It is a dense outgrowth of bone found on the lingual aspect of the mandible in the area of the premolars above the myloid ridge. The previous slide sounds are compliments of my Labrador Retriever rocky, shaking about. Okay, this is a picture of the mandibular tori on a radiograph. As you can see, it is radiopaque because it's dense, it's a bone. There's no treatment unless there's interference with fabrication or placement of a prosthetic appliance. Wanted to bring this out that I'm sure a lot of you taking the x-rays already have come across this. It makes it very difficult to take x-rays. Also, it's difficult for the patient to cleanse the lingual aspect of their teeth, and for us as clinicians to get in there and do scaling. This is a picture of the melanin pigmentation, the pigment that gives color to the skin, eyes, hair, mucosa, and gingiva is called melanin. Most commonly, the darker the patient's skin, the darker or more commonly observed melanin is in the mouth. Here's another variance of normal. It's seen in the retrocuspid papilla, as we had discussed earlier. It's usually found in adolescence, right behind the cuspids on the lower arch, on the lingual, and it presents itself as a sessile nodule. Sessile meaning it's broad, and nodulated meaning it's raised. And there's no problem with it. It usually decreases as the adolescent grows older. Lingual varicosities. Their appearance is red to purple. They're very enlarged, and they are in clusters. They appear on the ventral, which is the underside of the tongue, and lateral surfaces of the tongue. They're most commonly observed in individuals that are 60 years old or older, that have predominant varicosities on their legs, and also have a history of smoking and cardiac problems. Linea alba, or white line, extends from the posterior of the buccal mucosa along the occlusal plane to the anterior. It may be bilateral. It may be more predominant in patients who have a clenching or bruxing habit. This is a picture of leukodema. It's a generalized opalescence on the buccal mucosa. It's most commonly observed in Black adults. And you can tell if it is leukodema by stretching it, and the opalescence becomes less predominant. And of course, there's no treatment for it. Benign conditions of an unknown cause is called idiopathic, meaning unknown cause. These include the lingual thyroid nodule, median rhomboid glossitis, geographic tongue, fissured tongue, and hairy tongue. This is the lingual thyroid nodule. I think I've seen this just once in all my years. It's not very common at all. It is an undescended, trapped remnant of thyroid tissue. Its clinical appearance is a mass in the midline of the dorsal, the top of the tongue, on the back side, the posterior to the circumvallate papilla, in the area of the foramen cecum. It usually has a sessile base, which is a broad base that is 2 to 3 centimeters in width. It usually occurs with females linked to hormonal changes. There's no treatment that is needed unless the patient has an obstruction with swallowing. I think it would be more difficult to swallow my multivitamins. With this, since it is part of the thyroid, it is very essential that we find out if the patient does have the regular thyroid gland, the butterfly one in their neck, before any thoughts of excising this would be continued. The median rhomboid glossitis is a term used to describe a smooth, red, flat, or raised nodular area on the top part, the dorsum, of the middle or back of the tongue. The affected area of the tongue is missing its normal coating of finger-like projections called filiform papillae, which normally cover the entire top surface of the tongue. The name of the lesion reflects its location and describes the affected area being red. This presents a problem in patients if they have a lot of acidic foods, because missing of the filiform papillae, it lends itself for sensitivity. Here we have a picture of a geographic tongue. Its appearance is erythematous patches surrounded by white or yellow borders. The patient can come in 1 week and it looks like they have a perfectly normal, healthy tongue. The next week, after they've been under a lot of stress or, let's say, trauma, they may have diffuse, means different places of areas of devoid, missing the filiform papilla. That's where you see the bright red. Also, they have distinct presence of fungiform papilla. That's the large papillas. They appear to remiss and change in different times. That's why we call it, in different areas of the tongue, that's why we call it geographic, which is moving around. This is another picture of a geographic tongue. It is less red or erythemic compared to the last picture. I would say it's more pallor. We know that geographic tongues have a genetic factor in it. Also, stress plays a role in it. The patient may complain of burning, and that's associated with the decrease in the filiform papilla. And we would recommend them, of course, not to have acidic foods. And usually there's no treatment prescribed or indicated. Again, it's geographic because one day you might see it looking like this, and the next week it could be totally different. This is a picture of the ectopic geographic tongue. The term is used to describe geographic tongue found on the mucosal surfaces other than the tongue. Ectopic meaning in an abnormal place, mucosa, instead of the regular position, the tongue. The fissured tongue has a clinical appearance on the dorsal, the top surface of the tongue, and appears to have very deep grooves or fissures in it. The cause is idiopathic or unknown, and it involves genetic factors, probably. It's seen in about 5% of the population. Again, this is a variant of normal. Home care for the fissured tongue is to direct the patient to brush gently the tongue, or also to use a tongue scraper. And this is to remove the debris or bacteria from the tongue and the deep grooves. Again, there's no treatment necessary. The white hairy tongue has the clinical appearance of elongated filiform papilla, which are white. It results either as an increase in the keratin production or a decrease in normal desquamation, which is the peeling away of tissue. The home care is to direct the patient to brush the tongue gently with a toothbrush or use a tongue scraper to remove the debris. Lastly, we have the black hairy tongue. Its clinical appearance, the papillae are brown to black because of a chromogenic bacteria. The chromogenic is what gives it the color. Contributing factors can be from tobacco, foods, hydrogen peroxide, alcohol, chemical rinses, and again, there's no problem with them. They just look different. And we would direct the patient to brush the tongue gently with a toothbrush or to use a tongue scraper. That's because the long filiform hairs or papilla also entrap bacteria causing halitosis. Okay, this concludes chapter 1, and I look forward to reviewing it with you this coming Friday. The discussion question is, what is the difference between a macle and a papule? And what are the elements of the diagnostic process, and what variants of normal may be found within the oral cavity? Every week you will have a discussion. This is a graded activity and it counts for attendance. Please make sure that it is done completely to the best of your ability. For week 1, please make sure that you do the first part of the discussion by Friday, February 4th, by 11:59 a.m. Then make sure that you respond to another classmate's discussion by Friday, June 11th. After the first week of class, all assignments will be opened on Saturday at 12 a.m. This way, if you would like to get done over the weekend, you can. You always must complete your write-up every Wednesday by 11:59, and your response to a classmate's discussion write-ups will always be due on the Friday by 11:59 p.m. Looking forward to seeing y'all. Have a wonderful week, and welcome, 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 Cohort 15 to Term 7.